IVM.
Hi everybody, just wanted to ask everyone for a quick favor. We're running a brand survey right now and would really appreciate it if you could let us know what you think about the advertising on IVM. Go to ivmpodcast.com/survey and do let us know. As part of this, we'll be selecting 10 random participants and sending them some IVM swag, so do fill out those surveys.
Welcome to All Things Policy, a daily podcast supported by Pragati, a flagship media initiative of the Takshashila institution. We are a bunch of policy nerds based in Bengaluru, and we like to bring fresh perspectives to Indian affairs and an Indian perspective to global affairs. So grab a cup of coffee, sit back, and join us for today's chat.
Hello everyone, and welcome to another episode of All Things Policy. Well, it's the season of reports of all kinds. A few weeks ago, we read about the Pew Research. We also had an episode where we analyzed the Pew Research findings. The Pew Research mainly focused on attitudes of Indians on a host of social factors. In the last few days, we've seen another report that has been published. It is the Inequality Report of the Oxfam organization. This time's report has a special focus on India's healthcare or the public health system. So it's titled India's Inequality Report 2021, India's Unequal Healthcare Story. To discuss a few aspects of this report, some of its recommendations, and more broadly to discuss the basics of public health system in India, I have with me my colleague, Apurva Kumar. He is a senior program manager and manages the postgraduate program in public policy at the Takshashila institution. In addition to this, he has also studied the Indian public health system deeply. He teaches courses relating to them also at our GCPP HLS stream. The HLS is the Health and Life Sciences stream. If you're interested in understanding health systems, policy formulation around not just health systems, but any other public policy, do check out our course, the Graduate Certificate in Public Policy. The course begins on September 4th, so do get in your applications by that time. With that, welcome Apur.
Hey, thank you, Suman. Thanks for having me.
Yeah, just to give a little context on inequality and stuff, over the past few decades, we had this school of thought that said that economic growth was all that mattered. And as long as we focused on that, the problem of inequalities would take care of themselves. It was commonly believed that if we just focused on this, that would be enough. However, the events of the past few years have put some doubts on that. The pandemic has actually upended this line of thought and brought removal of inequalities, especially in the health sector, to the forefront of policymaking. The Oxfam report throws light on the public health system in the country at first, and then it goes into inequities exacerbated by the COVID-19 pandemic. So, Apur, what are your first impressions of the report on a very high level?
I think it's a very timely report, Suman, and of late, the NFHS 5 data has also started pouring in from few states. So actually, personally, I was waiting for someone to start doing the number crunching and come up with some socioeconomic trends using NFHS 4 and 5 data and so on and so forth. So it's quite a timely report. Before I delve into the details of the report, I just wanted to highlight the concept and the broad idea that this report address.
Sure.
So this report broadly addresses a concept called social determinants of health. It is a commonly used, taught, and studied and well-researched subject or a topic or an idea within public health sort of research. Which basically says that the health outcome of an individual or a group depends upon the socio-economic conditions of that individual or a group. And the lower you are in the hierarchy, in a socio-economic hierarchy, the poorer or the worse your health outcomes will be. Let me give you an example. So, for example, if you are a rural woman from a lower caste, in one of those EAG states, your health outcome with respect to antenatal care, postnatal care, will be poorer than the women from, let's say, Tamil Nadu or Kerala.
Okay, just for the benefit of our listeners, can you expand on EAG?
EAG is Empowered Action Group states. So these are like group of 8 states. Earlier they were like Bimaru states, Bihar, Madhya Pradesh, Rajasthan, and Uttar Pradesh. Right now, Assam, Chhattisgarh, and Odisha, they have also been added. So these are a group of 8 states. So this is what the idea of social determinants of health says, that lower you are in the socioeconomic pyramid, the worse will be your health outcome. In when I was studying public health, my professor used to teach this concept doing a activity. So this activity is called as privilege walk, in which our class was divided into like few groups. So someone was upper caste, let's say landowners, and a woman and a single woman from lower caste, so on and so forth. And we were given some roles, and the instructor would ask us to stand in one line, in one file, and every time she will say a cue, we have to step forward. So for example, she will say that all the landowners of this group, please step forward. So the landowners will step forward.
Yeah.
Then she will say, within the landowners, how many of you are from upper caste? So at the end of the exercise, you will see that there is a distinct and a visible divide within the group. The group that started from the same level are now at different levels of the society, and the most disadvantage is at the back of the queue
line,
and the most advantaged people are at the front of the queue.
Yeah, I think this is an exercise that is done for various things, to mostly to check privilege. I have seen it mostly to check privilege and things like that. Yeah, so what you're talking about, determinants of health, the report actually goes into it in detail in the second chapter. They begin with saying that the aggregates don't give the whole picture. Okay? The overall infant mortality rate is 40.7 in India. However, if you look at the variance between, across wealth classes, the rich is at 19.8 and the poor is at 56.3. That is really huge. So if you're going by just an average, numbers can lie, like we know. So if you're going by just an average, we are not getting the right picture. Therefore, it is very necessary to go into inequalities, like you mentioned, all the determinants of health. Some other figures that are quoted in the report is that literacy amongst women amongst the general category is 18.6% higher than the scheduled caste and 27% higher than the scheduled tribe women. So we know that literacy of women is an important determinant of health, right? So if that is a variance between all these groups, you can only imagine how much, how varied the health outcomes amongst all these groups are. So can you just elaborate a little more on this determinants of health? Some more factors. Literacy is one, right? And what could be the other determinants of health?
That's right. So I think you have pointed out very rightly that the averages actually mask some of the realities. So the averages would just tell you the average trend of the population of a state or of a country, but it won't you have to slice and dice to get into the nitty-gritties as to how these inequities affect different social groups. So on that you are quite spot on. So there's something called social gradients of health, which is actually which is also a term used within social determinants of health literature, which basically means the differences in health in your different groups. So gradients means the differences. So right, we have pointed out that the privileged sections would have better health outcomes, so on and so forth. There's a huge body of literature in nutrition and health research. Scholarship which says that the women's education outcome is completely sort of it results to better health outcome of her family or of the children. So a huge body of literature says that intergenerational nutritional benefits because of mother's education and her agency and her ability to take decision within the household actually impacts positively it positively sort of impact the health of the children and of the family members. Now if you have differences in health in educational sort of levels within women amongst the states, then we are in a big crisis.
True, true.
So, for example, better educated women from, let's say, southern states will have better outcomes, health outcomes. And so the health outcomes of the next subsequent generations would be better as compared to, EAG states or some of the states from Indian and North Indian belt. So education is one of the biggest factors. Second is household income or household wealth. So the lower wealth quintile, households will have poorer health outcome as compared to richer, because the richer would be able to access private healthcare services, because the public healthcare services is in shambles and it is being neglected. The quality of healthcare is not good. So they will move to public healthcare, but no, not the poorer households. They have to they have to endure, they have to be there in the public services, no matter how much no matter how poor the quality of services is. That classic Hirschman concept of exit, voice, and loyalty. So the richer can exit, but the poorer don't have the option to exit. So wealth is one thing, and also the caste and gender.
Sure. Yeah. I mean, what we're saying may appear pretty obvious, but what the report also points out too, and when you read it, it just feels like, yeah, why didn't we think about it? The lower the literacy amongst the women, the higher they approach for like curative, mostly, emergency services. The higher the literacy, you are more into preventive care. You are more into in determining or accessing better nutrition, better health, which are more of the preventive or the basic baseline that we need for good health outcomes. So that was one thing. Yeah. And some other figures out of that is that 2 out of 3 have access to non-shared sanitary. After literacy, they go to water and sanitation. 2 out of 3 have access to non-shared sanitation facilities in the general category, whereas the amongst the scheduled castes, it is much lower. They are actually about 29% behind the general category people. So we see that the social gradients are playing a huge role in health outcomes. Like the report also talks about the system, the public healthcare system, primary, secondary, and the tertiary. Could you just explain how the whole? I mean, most of our listeners, for the benefit of listeners who don't know how the public healthcare system is structured, could you just explain how the public health system is structured?
Right. So a rural healthcare system, a rural public healthcare system is divided into 3 tiers. And won't say 3 tiers, but it's actually 3 institutions that cater to the public the health sort of demands of the rural community. So at the bottom you have sub-centers. So sub-centers are small public health institutions that cater to around 5,000 to 6,000 people population. They will have one auxiliary nurse, midwife, and some basic medicines, so on and so forth. They don't do institutional delivery because they don't have infrastructure. If you move above sub-centers, you have primary health centers, PHCs. So every primary health centers, they cater to a population of 25,000 to 30,000 population, and there are 5 to 6 sub-centers that are tagged, or they come under one primary health center. So these primary health centers are the first contact point where institutional deliveries happen. This is the first contact point where the community interact with the medical officer in charge, which is a doctor. You have, as per Indian public health standards, you have 11 to 12 people that form the core staff of a primary health center. Above primary health centers, you have community health centers, so 8 to 10 primary health centers in a block or in a taluk. Above that, you have the community health centers. Community health centers are more upgraded. They have better funding. They have more infrastructure. They have specialists as doctors. So they have an obgyn, they will have a pediatrician, an anesthetist, so on and so forth. Above community health centers, you will have district hospitals. So if you have some complications or you need a referral, if someone from community health center or a primary health center, say you have, the doctor may refer you to a district health hospital because the infrastructure and facilities are better. So these are the 3 or 4 sort of tiers of public health institutions within a rural setup. Broadly, this is the same setup in some of the urban space because you will have suburbs and rural areas within a city. So this is a broad sort of structure. Then you will have tertiary healthcare centers within cities and big towns, and super specialty clinics, hospitals, so on and so forth.
Thank you for giving us an understanding of the basic public healthcare system in India. We'll be back after a break.
Hey, it's been another great week on the IVM Podcast Network. On the Edges and Sledges Cricket Podcast, in the first half, Ashwin is joined by Varun to wrap India's ODI tour of Sri Lanka. In the second half, DJ joins the party to discuss the first T20 international between India and Sri Lanka. If you'd like to hear more about this match, former Indian cricketer Sobha Karim joins Rajiv Mishra on Khel Niti and they talk some more about it. Ladies and gentlemen, we're really excited to announce a new show about crypto with Rohan Joshi. He's going to dive deep and demystify all this crypto stuff that we've been hearing about. And let me tell you a little bit more about stuff that's going on the network really quickly. Congratulations to Maru Kinayat, who celebrates 50 episodes of The Note with a discussion on health as a fundamental right. On Paisa Vaisa, Anupam talks to Harsha Chetanwala of mywealthcrow.com. Zarina Poonawala is starting a new miniseries on emotional intelligence. Do check out the kickoff episode on the Empowering series. And Simplified talks about semiconductors. Do follow us on social media. We're IVM Podcast on Twitter, Facebook, Instagram, and LinkedIn. And remember, if you're enjoying this show, or any other show for that matter, please do tell a friend. That's really helpful for us. And finally, we would like to thank our sponsors on the network this week. They make this all possible. Thank you very much, Ciet, Cred, Global Victoria, Bank of Baroda, Intuit India, Lenovo, and CoinSwitch Kuber. We really appreciate your support.
Welcome back. After that quick understanding of how the system is structured, it appears to be that the system seems to be well thought out in terms of plan, etc., on the ground. But how does it function? I mean, do you have? I mean, the understood thing is that they don't function too well. So as soon as people get a little richer, they exit and go to the private, healthcare. But are there instances of this system working really well in India?
So it depends, Suman. So in some states, some of these facilities, these public health institutions have worked really well. So, for example, Tamil Nadu is a prime example in which these systems have worked really well. I have done a lot of field work as a practitioner in Rajasthan, where the sub centers were actually non-existent. So they were just like 4 walls, and that's it. So this is what would happen, right? So, for example, if I'm a person living in a village in, let's say, rural Rajasthan, and I have an abdominal pain, the first contact point is the subcenter. I will go to a subcenter and I will find that there is no A&M and there are no medicines. What I will do, I will go to a primary health center. There also the doctor is not there because either the doctor is in a training or is on a leave or he's in a private facility. Then I'll have no other option but to go to a private healthcare provider or a private clinic in a city. So I have to travel all the way to the city to address my problem. This is a classic sort of approach that millions of people in India are following. So you have a neglected healthcare system. Then you have a private healthcare system. People are exiting neglected healthcare system, going to private healthcare system, and in private healthcare system, they are paying from out of pocket. That's why the report also says that 81% is privately funded. It's funded through out of pocket.
And the out of pocket is only increasing every year.
It's increasing, and the report rightly claims that 67 million people gets pushed to poverty every year because of out of pocket expenditure.
And I think with COVID, it's just going to get even more exacerbated.
Absolutely, I think it has worsened. So there is a lovely sort of a metaphor that I use. This is from the book by Anirudh Krishna, One Illness Away. So Anirudh Krishna, Duke University professor, he says that billions of Indians are just one illness away from the poverty trap.
Yeah. So this had an interesting point, which has also been, we have discussed, we have read about it elsewhere. COVID not only has caused caused a lot of suffering, just with COVID related issues, but even non COVID related healthcare has taken a setback hugely. For example, this report says that immunization has been put on hold in a lot of places. The regular immunization for children, immunization programs that we supposedly run very well. So now, if you have really disrupted the immunization system, it could affect millions. Another generation of children could really be affected in terms of just broad health outcomes. So the public health system is going to be even more strained going forward. So it brings us to the point of financing. I mean, how do we get the public health system back in shape? And it's a no-brainer that we need more money in that, etc. We are at a very low level of expenditure in terms of GDP. Everyone says we should be bringing it up to 2.5%, all those numbers. But can you give us an understanding of what financing public health care would actually mean?
So financing health. Right now, the government spends 1.25% of the entire GDP in healthcare. The recommendation for several years has been that you have to increase it by 2.5%, which I don't think is going to happen in next few years, because this was a pandemic year, and in the budget we saw a 10% increase of merely 10% increase of Ministry of Health and Family Welfare budget, which means that the signal is that it's not a high priority, right? And in one of the earlier episodes, I have spoken about how the welfare architecture of India is shifting. So the focus of Indian and state governments will be more to give private sort of services like electricity, housing, bank accounts, than to focus on public provisioning like health and education and so on and so forth. Right. So that's one aspect. The second aspect is that many people think that health insurance is a magic bullet. I completely disagree. Health insurance is just one piece of the bigger
the universal health coverage.
That's right. So my sort of it's a classic sort of a metaphor that's been used, that health insurance is not health assurance, right? Health assurance is what universal health coverage idea offers, right? That every single person, no matter what your identity or from which background you're coming from, you will get a quality healthcare service from all public health institutions without affecting your financial health. Right, that is the broad idea of universal health coverage.
It would start at prevention. It would include treatment. It would include rehab, and it would include even like palliative care if needed.
Exactly, and this is where we are missing the point. So health insurance or schemes like Ayushman Bharat, they are just solving one piece of the problem, which is the financial aspect. That too, that's right, and that too, right? PMJ is not even that greatly funded. So the budget is 65,000 crore, which is nothing when you compare with out-of-pocket expenditure, which by the way is 3 lakh crore. So this is absolutely nothing. Of course, I mean this is just a step. This is a good step, but this is not going to solve our problem of out of pocket expenditure or upgrading our health infrastructure.
It's just like a band-aid kind of thing at this point. Yeah,
that's right.
Yeah, the report goes into a few recommendations. It says that we should make. It takes a rights-based approach. Do you think it will work?
So personally, I think it should work. Personally, I would advocate for a right-based thing because this is what has happened in other countries also. And if you make, of course, I mean we can talk about the fiscal sort of limitations, but I'll just speak about the idea. So, right to health will say that make it a justiciable right. You move it from directive principle to, let's say, fundamental directive principles to part 3, and you associate it with right to life, and you will say that if that is being encroached, you can approach a court. So I think that should be the idea, so that all the government, all the subsequent governments, the citizens can hold them accountable whenever, after 5 years when they are going out for their votes. So they have the report card, and they can sort of, they can assess on, evaluate on those aspects. I think that should be a right approach, but it should be well thought. It should be well designed, because it should not fall into the trap where the right to food, the right to food sort of went into that, because the objectives of right to food were several. I mean, there has to be one objective, and you should solve that
Correct.
objective.
Yeah. So we spoke about, I mean, the report also talks about free vaccine policy. Yeah. In the light of COVID, probably free vaccine policy makes sense. It also has some things on price caps and stuff like that. But from what we know, that price caps will not work, right? So what do you think can be done for that? Because we need to see that these out of pocket expenditures, that's where the price caps are coming, right? For health, diagnostics, essential drugs, etc. So does a centrally sponsored scheme solve for that, or do you need more regulation around those things?
I don't think so that more regulation is needed. What the government can do is that they should just sort be an enabler, and they just let competition to take care of everything. So when you have several other players who are producing, let's say, stents or some of those basic things for which price caps were introduced 2 years ago, I think the prices would, the market equilibrium will kick off, and the prices would go down subsequently. But if you have an inspector sort of a overarching authority, I think that's not good for the healthcare market as well as for the citizens.
So few more recommendations that have been put in the report are the patient rights charter, which I think is a must do for anything. Also, it talks about stress on human resources, the ASHA workers establishing government colleges, etc. So the ASHA workers are an important link in the whole public health system. So I think there is a case for expanding that system and actually regularizing their work, or any of that. Of course, it will come with some fiscal constraints or so, but I think it's a good idea. What would you agree?
Yeah, I think so. And if I think over the past 4 or 5 years, several states have seen protests and demonstrations of ASHA workers and these frontline health workers across states. Karnataka, Chhattisgarh, Jharkhand, Rajasthan, and their the demands are like two or threefold. First, they should be regularized, because these are either contractual workers or they are sort of they are paid incentives as per the cases they bring to public healthcare facilities. So they should be regularized. Their salaries, if they are regularized or if they are on contract, their salary should be increased to match the daily wages thing. Secondly, they should be given some more incentives, because the back-breaking work, in fact, they are the spinal cord of our healthcare system. And if you don't incentivize them, and if you don't provide them better services, I think the entire sort of skeleton will fall apart. So some of these demands are actually quite valid. I don't think so that if you it won't sort of impact fiscal sort of discipline too much, because if you see the long-term benefits is huge.
The opportunity cost is.
That's right, and you have a better health outcome, which means there will be more productivity, which means it will impact the economic sort of development.
And finally, coordination with other departments, because public health is not just doctors, workers, etc. You are coordinating with the water supply, sanitation, and all other kind of departments have to come together. That policy of synergizing these different different departments needs to be worked out as such. So we're kind of at the end. So do you have any other final comments to make?
No final comments. I think the report, the recommendations of the report, some of them have been sort of spoken and talked about for a very long time by health activists and health scholars. I think it's high time we should sort of start acting on some of these recommendations, because some of them are just low hanging fruits, and we can start working on those things. So so as you said, that human resources, staffing, infrastructure, intersectoral coordination, I think these are low hanging fruits which are very very much in the hand of the state or the administration. We can start working on those aspects, and I think it's a gradual process. It won't happen overnight, but I think in 5 to 10 years, 5 to 10 years is what I'm sort of projecting. In 5 to 10 years, we will see some change, but it has to happen now,
action has
because that's right. Action has to happen now, because if not now, then never, I would say.
Yeah. So as we teach in our public policy courses, health has a huge positive externality, and really the role of the government is really very paramount in to increase these positive externalities. So there is a huge case for the government playing this role. So, I mean, while we don't confuse with healthcare, public health, we can draw all those distinctions, but really there is a huge case for it. And as citizens, I think we should demand our share of this public health that, we are all entitled to. With that, I would like to close this episode. Thank you so much, Apurva.
Thanks so much.
See you guys.
If you liked our show, don't forget to check out other interesting podcasts on the IVM network. You can tune into them on the IVM Podcast app, ivmpodcast.com, or wherever you listen to your podcasts. You can also follow IVM on social media. The handle is @IVM Podcasts on Twitter, Facebook, and Instagram. And hey, if you'd like to dive into Takshashila's research on technology, strategy, and economic affairs, check us out at our Twitter handle @TakshashilaINST or our website takshashila.org.in.
Whether you're an established sports person or a budding one, or simply a sports enthusiast, join us, Tanvi and Shlok.
We are two passionate pro badminton players talking policy, mindset, and everything sport.
So tune in to The Millennial Athlete every Monday.
Only on the IVM Podcast Network.
Trust us, it's gonna be lit.
A wise man once said, traveling, it makes you speechless, then turns you into a storyteller.
Well, listen to such travel stories and experiences exploring India on the Musafir Stories with us, Saif and Faiza.
Catch us on the IVM website, app, or wherever you get your podcasts from.